Good morning, everyone. This is Andy Reese, Director of Department on Disability Services. I just want to let you know in advance, after I do my regular presentation of the data, we're then going to have a presentation by DC Health. Andrea Coker will provide us information about a project that DC Health has been working on with the CDC, tele-ICARs, which she will describe, which has been a technical assistance and assessment regarding PPE use and other well, she'll describe the whole thing, but they've worked with all of our intermediate care facility providers. And so she has some data as well to share about that this morning. And I'm looking forward to hearing. I heard real good things along the way about how that was going. So first, I will share our current data. So to date, we have had 426 people who have tested positive for COVID-19, which includes 4 people in the month of April. Of those 426, 7 have been in host homes, 114 in intermediate care facilities, 1 in a mental health facility, 55 in their natural home, 2 in a nursing home, 4 in out-of-state placements, 37 in residential habilitation, and 206 in supported living placements. And so these numbers, the percentages haven't changed much since the last time we met, but in ICFs, the 114 people represent about 38% of the people who are in ICFs. Of those people in ICFs who have contracted COVID, 23 have died. However, only 12 of those have been confirmed as COVID deaths. So that accounts for 10.5%. In natural homes, the 55 people who have contracted COVID represent about 5.9% of the total. And of those, there have been 5 who have died, and all of those were confirmed as COVID deaths, which represents about 9%. In residential habilitation, 37 people who've contracted COVID represent about 34% of people in residential habilitation. Of those, 3 have died, but only 2 were confirmed as COVID deaths, which represents about 5.4% of people in residential habilitation who had COVID, who had a COVID confirmed cause of death. In supported living, 206 people who have contracted COVID represent about 22% of the people in supported living. Of those, there have been 21 deaths, but only 15 have been confirmed as caused by COVID, representing about 7%. So overall, within DDA, the 426 people represent just about 18% of the people supported. And of those, 55 have died, but of those, 36 are confirmed or presumed COVID deaths, which represents about 8.5%. So in the month of April, of the 4, 2 of them were in supported living, 1 in a natural home. The other one was in a host home, which I don't track month by month because over time, I think I said there have been 8 in host home. So month to month, I'm just tracking sort of the major placement types of ICF, ResHab, supported living, and natural home. People who have required inpatient hospitalization has been 1 of the 4 people in April who've contracted COVID, and that person is no longer in the hospital. There's currently no one receiving inpatient care for COVID-19. And as I had said before, there have been 55 people who have died. Of those, 12 have been confirmed as not COVID related, and we are still awaiting confirmation of the cause of death for 7 people, which is a total then of 36 people who have been confirmed as having died from COVID, none in April. And in fact, there have been no deaths in April of people who have had COVID. And amongst our provider staff, 685 provider staff have tested positive for COVID-19. 50 of these staff have worked for more than one provider, and 10 staff have died from COVID. Now, just a somewhat brief update on vaccination rates amongst the people that we support and staff. So for people we support overall, 67% have either gotten their first vaccine or completed vaccinations. 51% have completed, 16% have had their first dose. By placement type, in intermediate care facilities, we're at 94%, and residential habilitation at 92%. Supported living is at 74%, and those numbers are for people who have either first or second vaccination. Host home is at 59%, and natural home is at about 50%. Among our provider staff, provider agencies are reporting their total number of direct care staff in the aggregate, along with those that have been vaccinated. So we've had, as of yesterday, 73 providers who had reported, which accounted for about 5,100 total staff. And of those, 1,955 or 38% had completed vaccines. So we don't have a number for those who've had just one vaccine at this time. The positive news in that is that we do have 12 providers who have reported greater than 70% of their staff who have been vaccinated, including 4 who have 100% of, or one is 99.5, but we'll round up, of their staff who have been vaccinated, which includes a whole range from very small providers up to some of our larger providers. One of our providers at 100%, it's 200 staff out of 200 staff have been vaccinated out of 201 staff. So we are seeing some agencies with real success and really working on how we can share whatever strategies they've had with other providers so that we can see that success across the whole provider network. So next up, if we can shift the presenter over to Andrea Coker from DBH. She has some information to share about the project that DC Health, along with CDC, did with all of our intermediate care facility providers. You are still on mute, though, Andrea.
Hi, good afternoon. My name is Andrea Coker, and I'm a family nurse practitioner with DC Health. I'm part of the epidemiology department. So a few months ago, we had talked about partnering with our intermediate care facilities to do an infection control assessment virtually. So DC Health initiated a tele-ICAR program with our ICFs. Since August of 2020, intermediate care facilities in the district have reported 21 COVID-19 outbreaks prior to our pilot program. The risk of COVID-19 transmission in ICFs is thought to be high among owing to their home-like congregate environment. Persons living in ICFs have underlying health conditions that predispose them to higher risk of morbidity and mortality from COVID-19 compared to the general population. Recent assessments highlighted nearly universal deficiencies in infection control practices among 61 ICFs, licensed ICFs in the district, with 4 facilities receiving intermediate jeopardy citations from HARLA prior to the start of our tele-ICAR program. What is a tele-ICAR What is a tele-ICAR? So ICAR stands for Infection Control, Assessments and Response, and an ICAR is a process of on-site review and assessment of infection control and prevention activities in a healthcare facility during ICFs, including ICFs.
You know that we have lost the presentation, Andrea.
Oh, sorry.
There we go.
Okay. Sorry. What is tele-ICAR? The CDC ICAR stands for Infection Control Assessment and Response, and an ICAR is the process of on-site review and assessment of infection control and prevention activities in a healthcare facility, including ICFs. General ICAR tools existed prior to COVID-19 pandemic to assist health departments with assessing hospitals, nursing homes, dialysis facilities, and outpatient facility infection control programs. However, this did not exist for ICFs. CDC developed specialized ICAR tools for nursing homes shortly after the start of the COVID-19 pandemic. Tele-ICAR uses voice and or video conference devices as an alternative to the in-person infection control and prevention assessment and consultation. The CDC and other health departments have used tele-ICARs to provide infection control expertise for facilities that lack the resources or dedicated infection control prevention staff. This was primarily done for nursing homes. Facilities discuss current policies around personal protective equipment, PPE, hand hygiene, environmental clean and disinfection, screening, and notification for COVID-19 with subject matter experts. DC Health COVID-19 Emergency Response Healthcare Facilities HCF team worked with 12 of our ICF providers. One ICF per provider was enrolled. Tele-ICAR was scheduled in consultation with the providers as a pre-agreed time during the periods of November 2020 to March 2021. The Centers for Disease Control and Prevention, CDC, led 2 assessments. DC Health led 10 assessments with 1 assistance from CDC. The pilot program utilized ICF's existing video conferencing equipment to conduct the tele-ICARs. The healthcare facilities team worked with ICF administrators and directors of nursing to ensure the technological resources and the logistical details support the virtual assessment. ICFs designees provided real-time video walkthrough of the facility. The recruitment and selection criteria for the pilot's initiative: 12 facilities were contacted and ultimately enrolled. The original eligibility criteria was changed to allow for providers to select facilities for the pilot. DC Health originally wanted to only enroll facilities that had a known COVID-19 case or had been cited by HARLA for an infection control deficiency anytime after June 21st of 2020. Implementation process. DC Health healthcare facilities team interviewed through teleconference using Zoom and Microsoft Teams application for a duration of 1.5 to 2 hours. Verbal recommendations were given at the time of the assessments, and formal written reports were provided to ICF providers within 3 weeks of the virtual visit. The ICF staff interviewed consisted of CEOs, COOs, QIDPs, DONs, house managers, licensed nurses, and DSPs. Tele-ICAR pilots outcomes: 3 common infection control strengths were observed, and those included staffing, immunization, supply procurement, while 6 common infection control gaps were identified, and those included hand hygiene, the use of PPE, isolation and quarantine processes, screening process for healthcare personnel, visitors, and persons supported, clean and disinfection process, and general infection control measures. There were 12 written formal reports provided to our ICF providers. Common recommendations included discontinuation of test-based strategy for returning staff to work and improvements around appropriate reuse of PPE. So infection control strengths again, staff were encouraged to notify the providers and take time off if they feel ill or if they've been exposed to someone that had COVID-19. Schedules were readjusted to allow more time for staff to rest after intense periods of work. We did see a high influenza and SARS-CoV-2 immunization compliance amongst the persons supported. Most facilities had 100% compliance. Quarantining staff and persons supported together in response to household exposures or outbreaks mitigation periods. So whenever there was some facilities, when there were outbreaks, they cohorted the staff and the persons supported. Proactive sourcing of cleaning and disinfection supplies during periods of extreme shortages. We were aware that there were times where there were challenges with supplies, so some facilities used what they could get their hands on at the time. High SARS-CoV-2 vaccination, which is the COVID-19 vaccine coverage among management and administrative staff to promote vaccination among healthcare personnel, which is good due to vaccine hesitancy. Infection control gaps. Hand hygiene. So 3 out of our 12 ICFs had gaps in hand hygiene, and the gaps included insufficient alcohol-based hand rub throughout the facility, refilling or topping off of alcohol-based hand rub, and monitoring auditing labs. For refilling or topping off of alcohol-based hand rub, this process could affect the safety and effectiveness of the hand sanitizer. The use of personal protective equipment, PPE. 11 out of 12 ICFs had gaps in proper use of PPE that included improper storage of used PPE, such as the face mask or eye protection, and some of the staff were taking their used PPE, like their face mask and eye protection, home. We also saw improper cleaning and disinfection of used PPE. That's cleaning from the least to the most contaminated surface, but in some cases, it was reversed. There was knowledge deficit on the required PPE needed to be used for daily care versus for quarantine or isolation. We did see cloth face mask use in one healthcare setting, an ICF. There were gaps between mask and skin surface, and also gap between the eye protection and the skin surface. Isolation and quarantine process. 9 out of 12 ICFs had gaps in the process of isolation and quarantine. Staff not taking advantage of sick leave policy when they were COVID-19 symptomatic. 8 ICFs used test-based clearance instead of symptom or time-based clearance strategies for allowing staff to return to work. There were knowledge deficits on the difference between quarantine and isolation. Lack of cohorting policy or plan for new admissions, persons supported under quarantine after a high-risk exposure, or persons supported who test positive for COVID-19. Screening process for healthcare personnel, visitors, and persons supported. One facility had no pulse oximetry included in the person-supported assessment, and we did see inaccurate temperature measurements for healthcare personnel's or visitors' temperature. That includes getting a low temperature reading when someone is outside during the wintertime compared to when they're inside the home. Cleaning and disinfection process. 9 out of 12 ICFs had gaps in cleaning and disinfection process. Use of different types of disinfectants with long and or different contact times, and sometimes that got the staff confused, and some of the contact times were as long as 5 minutes. Some of the products that were used were not on the EPA list N, and we did see alcohol-based hand sanitizer being used to clean equipment, such as a thermometer. General infection control measures. 4 out of the 12 ICFs had gaps in general infection control practices. Example, sharing of the dining room table with persons supported and staff for breaks, sharing of bathrooms with persons supported and staff, the use of persons supported bathrooms for storage and supplies, the use of biohazard bags, red bags for all COVID-19 waste, storage of food and cleaning products in the same closet, improper use of diluted bleach product. A new bleach solution is prepared every 3 days instead of every 24 hours. Some of the common recommendations that we made included ensuring alcohol-based hand rub dispensers had adequate levels and are routinely replaced. Improve storage for reusable PPE such as the face mask or eye protection. Up-to-date return to work policies to utilize the symptom-based or time-based clearance methods, whichever is appropriate for the facility, and improve cohorting policies to appropriately use the terms quarantine and isolation, especially when accepting readmissions or new admissions. Improve screening practices for staff and visitors, example, accurate temperature checks. So sometimes we made suggestions instead of checking the temperatures outside when it's cold and getting consistently low readings, to bring in the individual in the home by the door and rechecking their temperatures again. Ensure pulse oximetry checks are included as part of routine screening assessments of persons supported. Use of appropriate cleaning and disinfection techniques for reprocessing of PPE. Some of the logistical challenges that we experience: scheduling and rescheduling assessments. Out of 12 facilities, 3 facilities rescheduled at least once and sometimes more than twice. There were issues with network availability and connectivity, and 5 facilities had challenges in availability of network and software. Limitations in viewing included sometimes we had intentional and unintentional restrictions. The benefits of the ICF, tele-ICAR and ICF setting: we provided one-on-one support from the healthcare facilities team to our ICFs. This strengthened the partnership with DC Health and the ICF providers. ICF providers had immediate feedback of our observations, and immediate implementation of tabletop recommendations were made most of the time, and updated guidance and recommendations of local and federal guidance were available to the ICFs. For other noteworthy items, DC is the first jurisdiction to formally implement prevention-based tele-ICAR visits. Formal interactions between state healthcare associated infection HAI programs and ICFs is a very new concept. CDC requested a copy of DC Health tele-ICAR template that DC Health developed for ICFs. The state HAI programs have traditionally only worked with acute care hospitals and some skilled nursing facilities. Again, no egregious practices were observed, which would have required reporting to HALA or DDS. This does happen occasionally when conducting ICARs in other healthcare settings. What are our next steps? Our next steps are to conduct an evaluation to gather formal feedback from the pilot attendees. So our ICF providers will be receiving evaluation tools within the next 2 weeks. Next step will be reaching out to the remaining ICFs for prevention-based tele-ICAR visits, and the anticipated start date will be mid-spring. This is to say, even though we started with 12 ICFs, our goal was the ICFs to use the same recommendations for all of their homes. So DC Health wants to thank the DDS and our ICF providers for partnering with us as we initiated our tele-ICAR program for ICFs. Thank you.
Thank you, Andrea. And if there are any questions, if people could put them in the chat so Andrea can respond, or if there are any other questions, I have not seen any so far. I do want to emphasize what Andrea said, the thank you to providers, that this was a process I heard that was that required on the providers' parts real transparency, openness, working with them, and an openness to learning about where they were with things. And from what I heard, this all went very well. That was very good news, I thought. It seemed to be a really good process, and I am looking forward to the report that comes back from the providers.
Yes. I'm not sure if this question is for DC. What was the vaccine status of the 4 people supported who tested positive for COVID in April?
So I had looked up just the most recent person, which the person had gotten their vaccine about 3 days before becoming ill and testing positive, their first vaccine. So of the people who tested positive, none of them had been even 2 weeks out from the from getting 2 vaccines, from getting even 1 vaccine. Since we've been looking at this, there has been 1 person that I have noted who had their first COVID vaccine, was scheduled for their second, but about 3 weeks after their first vaccine became ill, and that person actually was hospitalized and subsequently died. Other than that person, we have not had anyone who has had a vaccine and contracted COVID. We have had a few of the people who have been sort of right in there with one of the people in April was scheduled to get their vaccine, but got COVID first. So that vaccine's been delayed. I can look at the other 2.
Two more questions, Andy.
Okay.
What's the status for the list of people that will be getting their vaccines from their homes?
So those should be happening, if I'm not mistaken, and perhaps Winslow can respond to this. I think those are happening next week, beginning on Monday. And if Winslow could confirm that for me?
Yeah, so we were ready to move forward, but the uh, in-home people, or people who were going to get the vaccine in their home, were going to get the Johnson & Johnson, and as many know, that was placed on hold. DC Health has since developed a plan to administer the Moderna in 2 doses, and we've provided the list of people who we've assessed that could benefit from having the vaccine in their home. So, and it will start early Monday, I think early Monday, Tuesday next week.
Yeah, so the more thorough answer to that first question is 2 people had gotten their first dose just days before they contracted COVID. One person had reported that they were not yet ready to get a vaccine and then contracted COVID. And that person, just so you know, has been quarantined at home, has now recovered. And then one person, as I said before, was scheduled to get their vaccine, but before they got their vaccine, they got COVID.
I skipped the first part of that first question.
How has the concern about the vaccine been addressed? I don't know. I need to start back up at the top because I don't know what that person is referring to.
If you look at the last
follow up,
question,
because a lot of employees are concerned about taking the vaccines due to side effects. It's a split question. Somebody got a question in the middle. So how has the concern about the vaccine been addressed? Because a lot of employees are concerned about taking the vaccine due to side effects.
I think that we've reported and our providers have been reporting. So DDS has been providing some education to providers and providers. And I know that this has been the discussion at the nursing roundtable, and Winslow, you might have more information about that. But I also know that providers have been spending a fair amount of time, and perhaps some of them could type in the efforts they have been taking to educate their staff regarding vaccines.
so we provided a couple of trainings that included direct support professionals to explain even what vaccines are, the history of vaccines, and the minimal risk associated with vaccines throughout history. So, at this point, I'm we are also working on another effort to share information because there are staff who are hesitant to take the vaccine. We discussed that this morning on what efforts may be taken, and DC Health is going to initiate those efforts with our assistance to target those people who have concerns. I just, full disclosure, I completed my second dose of the vaccine probably 3 weeks ago. My experience was it was like a mosquito bite, and I had no side effects, just a little soreness in my arm. And the second dose, I had less soreness than from the first dose. And that's been almost a month ago. So, I mean, I think that the risk of catching COVID and becoming ill without a chance is much greater. If you catch COVID and you don't have this vaccine, you will likely possibly be hospitalized, and it could be the outcomes could be more severe if you don't have the vaccine. So, we can't make people take the vaccine. All we can do is encourage and teach. So, thank you for that question.
Yeah, just following up on that, I'll also say I had my second dose March 27th, so about 3 weeks ago as well. And in terms of, I fortunately experienced no side effects whatsoever. And I've said to people, it may have to do with the solution that the vaccine is in, or the needle with which it's administered. It was one of the easiest shots I think I've ever had because you barely even feel yourself getting the shot. And I was lucky enough not to have, I mean, what I have heard from people is soreness in their arm, sometimes some other, the day or two after feeling ill because their body is developing that immune response. I just have to go back to 685 provider staff have tested positive for COVID-19, 426 people we support, of whom 55 have died, 36 where it's been directly attributable to COVID-19, 10 staff have lost their lives. So when I compare that to soreness in the arm, some even from like people who have experienced more symptoms, that kind of achiness, maybe a low-grade fever, as your body develops immunity, on balance for me, it's an easy decision to make. I hope that people, as they have questions and concerns, that they find someone to ask these questions of so that we can move past this.
I will tell you, my experience is similar to Andy's. I'm 3 weeks past my second. And for both shots, I had general soreness and a headache the next day. That was it. So a little bit of aspirin, drank a little bit more water because I was dehydrated. And that was the extent of it. I do know that folks who have had COVID and then get the shots after they've had COVID get some reaction because I think their body is probably saying, hey, I recognize this. This wasn't fun the first time. And so they've got more trouble on the shots than otherwise, but it's pretty benign. And I did Pfizer.
So a comment from someone, which is very helpful. So this particular agency, I assume, has hosted question and answer sessions with their nurse for those who have been hesitant. They've also had some success in welcoming people in the wider community who were also hesitant and later chose to get vaccinated to share their stories, because many of the admin team opted to get vaccinated without hesitation. It was beneficial to get those other perspectives in the room. And I think, one of the things in Andrea's presentation was the percentage of that there was an impressive uptake of willingness to take vaccine amongst the administrative staff in the ICFs. And they saw that as positive for sending a message to staff about getting their vaccine. But I agree with the statement you've made here that I think probably more persuasive for a lot of people will be their colleagues and friends giving them that information than their agency director or me talking about it, because they will be able to speak to the specific concerns that they have. And as I say, I hope that people who have concerns will speak with someone about them so that they can talk them through. There's a reminder, Health and Joy has a monthly Zoom party that everyone is welcome to. It is the last Friday of every month, which would be a week from today, from 6 to 7 p.m. You can contact Haj from Health and Joy to get information about how to attend this monthly Zoom party with a live DJ. Actually, the link is in the chat for people who need that.
That may have just gone to you, Andy. I don't see that.
Well, then I will copy the link in the chat. That should have done it.
Yes, see it.
Another agency, we've done vaccination hesitation training, meeting every 2 weeks with DSPs and hosting a vaccination clinic. I hope that's been successful for you.
Excuse me, Director Reese, the time for this Zoom meeting, I think I missed it. I might have been.
It is from 6 to 7.
Okay, thanks.
The last Friday of every month. There you go. Since there aren't questions just in this moment, if there are people who are willing to share who were hesitant and decided then to get the vaccine, if they could share what it was that helped them make that decision after initially being hesitant. Because I'll admit, I have not been hesitant at any point in time. And as soon as I was able to register to get the vaccine, I did. But I appreciate that there are some people who felt hesitancy, and it would be really helpful for those who are feeling hesitant to hear what kinds of things that person considered in deciding they would get the vaccine, if anyone, as I say, is willing to share that.
Do they have to post it in the chat and then you can unmute them?
Correct. Well, or if they would just type in their experience in the chat, we can share that with people. So multiple people have shared an article that has been shared in the chat that helped them in their decision-making process. I will admit I am cautious because at times when I have clicked on links from the chat, I then end up knocked off of WebEx and have to log back in. So this is an article that was posted on NBC's site for people that would like to click on it. It is from Dr. Eugenia South, who just the introduction says, I'm a Black doctor who did not trust the COVID vaccine, and this is what changed my mind. And so it is a pretty, it looks like easy read and could be very helpful to share with people. And she kind of walks through what all the concerns could be, both about vaccines generally and this vaccine in particular. I'll read it later. I was starting to get to it. Thank you for sharing that because it does look really interesting and could be very helpful. And for those agencies that are doing regular training and listening sessions, it may be a really good thing to share. So far, I don't see any other questions. It's 12:52, so we will stay here until 12:55, unless we get questions, but otherwise can sit quietly for 3 minutes and then hopefully enjoy a nice weekend. So it is 12:55. I hope everyone has a great weekend and we will talk again next week. Thank you.